Welcome back to Against the Grain. My name is Dr. Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Today we venture into the realm of complementary and alternative medicine, also known as CAM. These include various diets, supplements, and other lifestyle interventions that are not part of the standard of care. A significant proportion of patients with inflammatory bowel disease try these treatments, often without informing physicians. As a result, many of these methods are simply unknown to the medical community or are dismissed due to lack of research proving efficacy. However, the reality is that most of the time there isn't an actual study saying these do not work. It's just the research hasn't been done, likely due to lack of funding or frankly lack of interest. Or any study that has been published is often of low quality or is inconclusive. Today we speak to Reid Kimball, who is a filmmaker who also happens to have Crohn's himself. He has made a documentary called Crohn's End, which is one of the most comprehensive investigations into complementary and alternative treatments for inflammatory bowel disease. As a disclaimer, this is a frank conversation with him about what he has learned, and this is by no means a recommendation or an endorsement of any of these therapies for you. As with any treatment, including any complementary or alternative medical therapy, you should decide if this is something you want to try on your own, but this should always be in conjunction with your treating physician and your gastroenterologist so that you can be properly monitored and they can also determine if this is something that's appropriate for your particular case. Thanks for coming on the show. So, as I mentioned in the intro, you are a filmmaker and you've made this movie, Wanted Crohn's End. So I just wanted to ask to start out, what got you involved in making this documentary?
Okay, yeah. Well, first of all, thanks for having me on the show. Really looking forward to talking with you about all of this. It's really fascinating. So what got me involved in it? Well, let's see. I started using the SCD after really having a tough time with Crohn's disease for about 8 years. The SCD, for those listening that don't know, the specific carbohydrate diet, and had a really, really successful turnaround with that. Symptoms went away within 24 hours, and then just started using it over the years. And in the back of my mind, I was always like, man, this is such a crazy story. I can't believe this is happening. And I would meet other people online that had similar stories, and we're like, we need more people to know that this is possible. So that was always in the back of my mind. And I'd gotten laid off from work as a video game designer, and I lived a frugal life, had a lot of money saved up, and I was like, you know what, it's now or never. And I jumped into it. I wasn't a filmmaker, took maybe one video editing class in college, but I just had this mentality of I need to do this now or it's never, and just threw myself into it, gave myself a lot of freedom to make mistakes and learn as I went, and was doing some research. And the town that I was living in, I found this guy had a blog, and he posted a bunch of videos. So I reached out to him as kind of like, hey, do you want to help me with this project? And he was really cool, really eager to get involved. And so he became kind of like my producer, my assistant. And together we just started on this journey of starting the Crohn's End blog and doing the movie.
And so where can people find the movie? So you have a website, right? Crohnsend.com?
Yep. Yeah, that's the place to go. So that's CROHNSEND.com. Yeah, and the front page of the website, there's a video, and that video is a trailer, but it's hosted on another website. And so through that trailer, there's some buttons on there that you can click that will enable you to either rent or purchase the film. So it should be easily accessible from that website.
And what can people expect to see in this? And the way I watched this movie several months ago, and I remember it being one of the most comprehensive looks at complementary and alternative medical therapies and lifestyle interventions, that type of subject matter. It's one of the most comprehensive looks at this that I've seen ever done on film before. And I really don't think this subject has really been formally broached like through film. Like you see YouTube videos on different types of things people are trying in the IBD community, but I've never seen a film that really kind of put everything together that everyone's talking about on all the forums, all the patient forums, and actually going to people who are trying these and the people who are kind of advertising or saying these things work, and actually really going to their house and seeing how they're doing these things.
Yeah, I'm glad you really appreciated that, because that was a goal of mine. I had several goals. So one of them very early on was to just show really positive, inspiring stories of people being able to overcome the challenges with IBD. If you recently get diagnosed and you start searching on Google, you're going to see all kinds of horror stories, and that is largely the reality. That it is a very difficult disease to treat and to manage and to live with. But I just wanted to show a different side, that there are other that overcoming them is a possibility. And so, you're right that it is really comprehensive in terms of like all of the different treatments that are available. But more important to me were the personal stories of, being able to visit people in person and see them actually go through the motions of like cooking their dinner, or even doing something as crazy as fecal transplant therapy. Or as I like to call it, human microbiota transplants. And so I just felt like it was really important to, that's the power of film, to really have this intimate look at people's experiences and their perspectives. And I felt like to really change the conversation, if this film, could do that, change the conversation within the medical circle of like what's possible, what therapies are valid and useful for people, that they really needed to have a really close, intimate look at how people that are overcoming their conditions, how are they doing that and why? Like I spoke in the first quarter of the film about the difficulties that people have with current treatments, and often it's those difficulties that really push people to just go off the normal path and try something different, try something alternative, try something that's not really well tested. And the final comment that I'll make is, yeah, you do see a lot of videos on YouTube. But I felt like there needed to be something that, it's almost like, you can learn anything on YouTube, but you're just going to get these little tidbits of information here and there. But if you buy a book, like, you're going to get the foundation. You're going to get, the foundational information that you need, and it's going to build on it from chapter to chapter. And that's kind of what I wanted to do, was like have really in-depth information about like what's going on in the gut scientifically. And those are the conversations that I've had with Dr. Karan. And then just build on that, and then end the film with like my lessons learned in terms of like, I learned a lot in terms of like what treatments can work, but also more importantly, like, is there a strategy? And yeah, I do believe that there's a strategy that people can use. I feel like that's the biggest thing that's missing. Anybody can like read online about like ginger and human microbiota transplants and SCD and just try things, but there needs to be a really comprehensive strategy that, because as your 2015 paper says, like IBD is multifactorial. Like there's multiple components that contribute to the disease progress, and if you don't have a strategy that addresses all of that, then you're just kind of taking stabs in the dark, and you're not going to be as successful as you could be.
Right. Yeah, every disease really comes down to as far as figuring out the cause of the disease. Besides infections, and even infections maybe this may apply to, but it's usually a genetic predisposition and something in the environment triggers it, right? And that's the case for every disease. And that's not very helpful information for patients because, number one, you can't do much with your genetics besides the expression of genes, like epigenetics, and
right.
Maybe there's certain lifestyle interventions you can do to help with that. And then the environment, especially if you're a patient seeing a physician, usually they don't tell you like, oh, it's this environmental trigger. They usually say it's something in your environment. We don't know what it is. We're trying to figure it out. And there's lots of theories out there about what causes Crohn's disease, what causes ulcerative colitis, as far as that environmental trigger. And it can get overwhelming because some people say, oh, it's Mycobacterium avium paratuberculosis. It's a particular bacteria, or it's E. coli, or it's the fact that you have a less biodiverse microbiome, or it's something like a food additive in the diet that's disrupting your gut barrier. And there's just tons of these. There's even a theory that it could be because of refrigeration. There's something called the cold chain hypothesis, where with the introduction of refrigerators, there's been growth of certain bacteria because our food is cooled that have led to these diseases. So there's many theories, and I do believe that ulcerative colitis and Crohn's disease are two phenotypic expressions, like two consequences of multiple different causes. Like there's probably many combinations of different things that lead to a final common pathway, which is either ulcerative colitis and Crohn's. And for that reason, and I know this, you know this, Reid, that different things work for different people. And ultimately, it's a trial and error type of thing when it comes to medications. It's true with medications. It's true with lifestyle interventions, these herbal supplements. Certain things work for certain people and other things work for other people. And that is part of the problem with doing research in this area because it's such a heterogeneous disorder that investigating a certain treatment in a large group of people, maybe it's no better than placebo, but maybe there's a few people that do derive a benefit from it. And then is it not worth trying if it can help just a few people, especially if the downside is low? So that's my attitude regarding these complementary and alternative treatments, is that if the downside is low, if we don't know of any major side effects associated with it, particularly with diet, I'm all for trying it.
Yeah, absolutely. Yeah, I've always thought of, like, in the beginning of doing research and making the film, like, my argument for, like, why alternative treatments, especially diet, needed to be promoted more is that, oftentimes it's safer, you're not going to get side effects, it's cheaper, and it's a lot cheaper than if you don't have insurance. Something like Remicade can be like $20,000 a year. So there's all these benefits, and it's like, as you're saying, if you can try it and it helps you, like, why not? You've got nothing to lose.
Right.
Yeah.
And just to play devil's advocate to this, because I'm a practicing gastroenterologist now, and I see the other side of the curtain. I started as a patient. I kind of started in this realm of looking into these treatments, and now that I've gone through all the formal training, to become a specialist in this area. I do think, the medications, they do have a proven track record. Yeah, they have these side effects that are associated with them, but they tend to be very rare. Now, I do remember one part of your documentary, and I think you had a patient on who, I forgot his name, but I know he was terrified of Remicade or similar medication, and he just didn't want to. His assumption was, if I take this medication, I'm going to get lymphoma. It seemed like he was convinced that at least the way he was rationalizing it was like, oh, why would I want to take that medication and end up getting lymphoma when I could try these other alternative treatments and potentially beat this disease without that risk. Mm. And I just remember thinking, I used to have that attitude, before I had this, I've gone through this training, but now that I've seen so many patients, like this is exceedingly rare. First of all, with lymphoma, the risk of lymphoma with Remicade and similar medications, if it's, for a while we said there was no risk, but there is some newer data that there may be a slight increased risk. But the risk of you getting into a car accident, driving a car is orders of magnitude higher than what it would be for getting lymphoma from Remicade. And I've never seen it in thousands of patients I've seen on these medications, Humira and Remicade. I've never seen someone get it. Obviously, there probably are people who get it, but it's just a very rare thing. I definitely agree. That getting into a car definitely has a lot more risks than taking most of these medications. Prednisone, though, like universally, right, that across the board, people have all kinds of side effects with that. Sure.
Moon phase, irritability. Every person that I've talked to, and correct me if I'm wrong, I'm sure you have more patients that have taken prednisone than Remicade. All right, let me ask you that. Like, for the patients that you have that take prednisone, do most of them deal with side effects, or is that an incorrect presumption? Incorrect view in the world of patients with IBD?
Sure. I mean, it depends on how long you take it, right? Our goal when we use, the prednisone is demonized, and I've been on prednisone. I know it's terrible to be on it for several months at a time. I personally had several side effects related to it, and most people will get side effects if they take it for more than a few months. They tend to be 100% reversible when you stop it. However, sometimes people do get, adrenal insufficiency that can be permanent, and they have to stay on prednisone long term if they've been on it for years and years. But the thing about prednisone is that it's one of the fastest acting medications. Right. So it may be needed in urgent situations, and it can be a life-saving drug. Before there was steroids, going back, in the early days of inflammatory bowel disease, this was a disease that had significant mortality, particularly ulcerative colitis. People would die before this drug was available. So that's kind of the counter argument, and I'm not saying these things to give anybody a hard time, but it's just playing devil's advocate of like why physicians use these drugs is because they help to get things under control more in the acute setting. And our goal is always to get people off steroids as soon as possible. And that's part of the reason Remicade was developed, is to get people off steroids and as a steroid-sparing medication.
Yeah, I totally get that. And, that's why, I never push for people to do diet or human microbiota transplants. Or I think people, it would be, I don't know if this is the right term, it would be a double standard of me for me to yell and scream about my documentary and say patients need to have freedom to choose alternative treatments, but then me to tell people that they can't take their prednisone and Remicade and Humira and whatever else. Whatever treatment that a patient wants to try, they should absolutely do that. And with how fast acting prednisone is, that's why I think it's even more important that there's more of a comprehensive strategy in terms of, like reading their Crohn's and Colitis Foundation of America website. Their strategy is to induce remission and maintain remission. And I'm like, that's not enough. It's got to be more comprehensive than that. So yeah, do use prednisone to induce remission, but then let's bring in more healing tools that can actually seal leaky gut, increase mucosal healing, increase the diversity of gut microbiota, and that's where the more natural treatments come into play, because it's the food that we eat that the microbes feed on and grow, and then create mucosa barrier, and then the microvilli can grow and heal, and then you've got disaccharide enzymes that are produced from the microvilli. So that's where I feel like we really need a comprehensive strategy that can include both standard Western medicines, but also these more natural treatments.
So that's where we get into this 5R framework, which you describe in the film. Before we get into that, and I know diet is a part of that, but you mentioned that this kind of all started with a specific carbohydrate diet and how you had success with that. So I just wanted to briefly go into that and your experience with the diet. Are you still on the diet? And just generally, what your opinion is with that diet.
Okay, yeah. I think it's awesome. I think it's an amazing first step that most IBD patients should start with. So, excuse me. Okay. So yeah, I was diagnosed as a 17-year-old in 1997. Was on medication for about 8 years. Didn't really work well for me. I was a teenager. I didn't know how to advocate for myself. Got to a really bad point, and my grandmother had suggested to my mom that I should look at this specific carbohydrate diet. So I was home for Christmas, and I started on it, and within 24 hours, I had my first solid bowel movement in over 8 years. I was like, wow, okay. This is it. I'm doing this. And over the years, I just stuck with it religiously, just absolutely fanatically, just wouldn't touch grains, wouldn't touch sugars. And so it came to a point where, let's see, that was in, what did I say in my film? Was it 2004 that I started it? Something like that.
Okay.
I think it was 2004 that I started on the SCD. And so over the years, every once in a while, I would try to go off of it. Not often, maybe once or twice a year. And I would relapse. I would have diarrhea, gut pain, and I didn't feel like I was getting all of the healing that I needed. And I wanted to see what more I could do, what else is possible. So I had the opportunity to do the documentary and just started doing a lot more research in terms of like what else was out there. My first interview was somebody doing helminthic therapy, microscopic parasites. And so, yeah, does that answer your question?
Yeah, so that's not typical. You referenced this paper I published in 2015, this case series, which anybody can look up. It's actually free to view. It was the specific carbohydrate diet, a case series. That's the title of it. But we had 50 subjects in the study and we confirmed their diagnosis. And these were all people who were in remission on the specific carbohydrate diet. And we just reported what these people were doing. And some of the findings we found out is most of them used yogurt. And another key piece of information was that people tend to have gotten some response in about a month, and then most people were in remission in about 3 months, clinical remission. So the fact that you felt well just after 24 hours is, and that may have something to do with where your disease is, and some people who have more colonic disease, more bleeding, and more distal disease, it may take longer to have an effect. But that's great that worked so quickly for you.
My thinking on that is, I've never had colonic bleeding. My Crohn's is in my ileum. Maybe that's a factor. When this was happening, I was put on an antibiotic. I think it was Flagyl. Yeah, it was Flagyl. And I had like the worst gut pain I had ever felt, the most explosive diarrhea from that. And this was in late December when I was taking this and having this happen. And I just basically like stopped eating and wrote home to my mom. And she's like, well, you'll be home for Christmas in a few days. We'll start you on the SED. And so maybe there was this process of like cleansing my gut and not eating a whole lot. And got home, and I did do the 24-hour fermented yogurt. So maybe that had something to do with it. But yeah, I don't know.
Another thing, just another part of this symptomatic benefit is that, you felt well over 24 hours, but we know in Crohn's disease that how you feel doesn't always correlate with how things look on the inside. Yeah. It's actually, there isn't good correlation there. So, but over time you had stability of your symptoms. So, I mean, it's important you feel well. I mean, I think we tend to, as gastroenterologists, just on the other end of the curtain, is that we tend to focus on what the colon and the small intestine looks like endoscopically, and that's the most important thing, that we need to heal the bowel, and that's our goal with these medications. However, we also have to pay attention to what the patients feel like. And that, to me, is equally important, is that we need to, symptomatically, if you're doing something, and even though there may not be data right now that it absolutely heals the bowel, but if it makes you feel better, I don't see any reason why you should stop doing something that makes you feel better.
Right. Yeah. Both are important. If a patient comes in and you can see microscopically that things are not as well as they need to be, but they're feeling better, celebrate that. You're feeling better. That's great. Keep doing what you can do. But we may need to look at doing something else, add to your regimen to see if we can get some more clinical response in your intestines. Vice versa, if you're getting really great results with healing of the intestines, but the patient's not feeling well, again, like you need both working together.
Okay, so let's get to the 5R framework.
Okay.
So my understanding of this is something that, based on your interviews, your work through this documentary, you've come across this framework, and it's the most comprehensive way to attack this disease from your perspective. Yeah,
absolutely. I just want to make clear this isn't something that I invented, and it's not patented or anything. I've seen this framework. Initially, I found it as the 4R framework in the chiropractic circles, and I've seen other naturopathic doctors also use this in their practice. But I felt like there was one component that was missing. So I'll just go through all of the components. And before I get to that, a thought that I have that I don't want to lose is that we were talking about earlier, you were talking about how, like, it's really confusing. There's all of these different factors that could be causing these conditions. It could be genetics, could be environmental factor. You were talking about the refrigeration theory, which I hadn't heard of before. And I feel like all of that information is just incredibly daunting. Like, how do you make sense of it? And so I really feel like a framework like this can help with that. So that's the problem. Like, how do you handle all of the information and all of the factors that are contributing to your condition? Well, I feel like this framework can help. So first, these are not in any order particularly, but usually you start with remove. And I feel like something like the specific carbohydrate diet or the gut and psychology syndrome protocol, which is more what I follow these days. I think your earlier question was, am I still on the SCD diet? And I would say I don't follow it 100%. So I'm more like paleo or GAPS, gut and psychology syndrome.
Okay.
So, and I can talk about why I made that switch. But with the 5R framework, first you're going to start with remove. And the first step of the SCD is like get rid of grains, get rid of sugar and starches. So it's going to be removing the chemicals, food, and toxins in your environment that may be inflaming your intestines. And so again, like, what is that in our environment? And for me, instead of like trying to figure out exactly what it is, I just get really fanatical about it and I just remove everything. It could also be like toxic relationships and stress. So that's remove. And then replace. So replace your diet with healthy fats, nutrient-dense and toxin-free foods, supplements to fix deficiencies. So like vitamin D is something that across the board consistently patients with IBD have been shown to be low in. So I constantly supplement with vitamin D.
Okay.
Reinoculate is the third component of this framework, and that is to reinoculate your gut ecology with beneficial microbes. That could be bacteria, yeast, helminths. I believe that eventually in the near future we'll probably find that there are beneficial viruses that we need, and there may be probiotic viruses that we'll be taking. So then the fourth component is repair. So obviously there's a lot of damage that's done to the intestines and to the mucosal layer. So we need to repair that damage using supplements or just sleeping as much as we can, because people do not get enough sleep these days. And that's where most of our healing is done, is when we're sleeping. And the fifth component that I thought to include to the 4R framework is reconnect. It's more of a spiritual component where you need to reconnect with what you really value and what you're passionate about in life. Often with IBD, so much is taken away from us that we need to reconnect with who we are and what we have in life. Be grateful for what we have. Reconnect with loved ones. Reconnect with our body, our mind, and our spirit. So using this framework, I feel like you're going to use many different treatments that will cover all of the different multi-faceted aspects of like what could be contributing to your IBD.
Yeah, it's very interesting. It's a very comprehensive look at kind of all the components that may go into the pathophysiology of the disease. So some of the interventions to address each of these components, they intuitively make sense, but obviously now we don't have the research to show definitively that these things actually do what is advertised, right? And that's the problem. But again, if the downside is low, it's probably not going to be very harmful to try these things. And
Yeah.
I wanted to go back to what you said about the diet, the SCD, and now that you're on the paleo or the GAPS protocol. I've had a similar experience in that. Or how long have you been on diet in general? I know you've switched to like different protocols, but I've been on SCD for about 10 years now. But like you, I think SCD, and I wrote this in the most recent paper I published, like a review. I published a review going through all the diets that have been published regarding treatment of IBD, and also ones that are in the lay press. So I'm sure you've heard of these. Like there's the Life Without Bread diet, where you just restrict carbohydrates. There's the raw vegan diet. There's the IgG4 exclusion diet. There's the Maker's diet, the SCD diet, the GAPS diet, paleo diet. There's a lot of them that exist, and they tend to have certain commonalities. But I think that a lot of people start with the SCD, and I think the reason for that is it has the most like anecdotal success stories online. And I don't know where you went to find it, but for me, one of the first places I went was Amazon, and you see hundreds of reviews that are positive. But,
it's amazing.
But it's always exciting for me to speak to another person who's been through this experience, because now I think both of us have been on this for multiple years, and but when you're starting out, especially in those like earlier days, it was really hard to find someone that you could speak to, actually talk to, who had been on this. And you just see these reviews. You don't know if these are real people or like where these reviews are coming from. But it's the SCD tends to be where a lot of people start. But what I've seen is that at least a good proportion of them over time, as they become more and more stable, they tend to figure out even things within the SCD they may not tolerate, and then they sometimes branch out and find things that they could tolerate that are not part of the diet. And that's after years. That's after like years, and it's a lot of trial and error, and a lot of experimenting to figure that out.
Yeah, one thing, gosh, there's like a train wreck of thoughts in my head right now. One thing that really is sad to see is that people fanatically stick to the SCD without trying to remove things that may be causing them, I don't want to say harm, but that just isn't working for them. And I feel like they have to follow it to the letter. And I feel like, yes, in terms of like what you shouldn't add when you're starting the SCD. You shouldn't add things that the SCD doesn't recommend, but you should definitely take away things that it recommends if they're not working for you. And so definitely people need to be able to customize for what's going to work for them. The SCD may recommend like tomatoes, but that doesn't work for me. Or like GAPS recommends sauerkraut, but that absolutely does not work for me. So I don't do that. I've been doing dietary interventions for about 14 years now. Okay. So I've been doing this for a long time, and I have no plans to change. My health has gotten to a state where I can eat cookies and chocolate, and I don't experience any symptoms at all. But when I eat those foods, I'm like, that was nice. I don't miss them. I don't need them. So I'm on this dietary intervention path for the rest of my life. And the other thing I wanted to say was wisdom of the crowd. So a lot of these interventions don't have a lot of studies behind them. But when you go to Amazon.com and you look at the reviews, like what you're getting is the largest clinical trial ever. It's just people publishing their own data. Yes, it's anecdotal and it's not by the same standards as medical research, but I wouldn't be where I am today. I wouldn't be as healthy as I am today if it weren't for me being able to see what other people on the internet have said has worked for them. And I've come across like a lot of really strange things, and I'm just able to, I'm able to suss out like what's real and what's not, what's dangerous and what has low risk. And so I feel like it's really important, like if you have that filter, to be able to filter out like what's potentially dangerous and what isn't, and what is coming from authentic, credible voices. You should be able to listen to what people are saying online. So you look at like the SCD community, there's many stories of people doing well with that intervention. Mm-hmm. And so that has value. It has value.
Right.
I feel like, it shouldn't be completely discounted.
Yeah, it's the best we have. And, around the time that I started doing published that case series and did some studies about the microbiome and SCD, around that time there were very few people looking into the SCD. I think at that point there was only one case report published on it. But now there's a huge amount of interest in it. So I think things are changing. There is a randomized controlled trial, which is going to be very interesting. It's a multi-center study comparing the specific carbohydrate diet to the Mediterranean diet. And the Mediterranean diet is actually a diet that is recommended by many physicians across multiple disciplines, and it's thought to be one of the healthier type of diets when they've studied that. And obviously, what are the differences between the SCD and the Mediterranean diet? The Mediterranean diet allows grains. It allows, although it tends to be more fruits, vegetables, lean meats, nuts, and like good fats. And but I think it does allow grain, so that may be one of the major differences there. But and SCD has many more restrictions when it comes to preservatives, food additives, sugar, those types of things. But here we have a trial that is controlled. There is a controlled diet, so that they have a control to help prevent the placebo effect leading to inflated results, or otherwise accounting for efficacy. And they're going to look, I believe they're going to look at hard outcome measures, like they're going to actually scope patients and see if there's healing. And the diet is actually, the meals are being mailed to people.
Wow.
Like they hired a commercial kitchen to make SCD meals. So it's a very controlled thing. It reminds me, I don't know if you've heard of Dean Ornish. Dean Ornish is a cardiologist who came up with this very low-fat diet that he was giving to patients with coronary artery disease, and it's one of the only interventions that's been shown to actually reverse coronary artery disease. But he's been criticized because it wasn't just diet. He actually told people to quit smoking, and I think they did stress reduction activities, and there was other things involved in it. But I believe this trial was done where they provided all the meals, and these people were like locked up in a hotel, and it was done in a very controlled fashion. So it'll be interesting to see what the results of this will be.
Do you mind if we talk about that for a little bit? I mean, the Mediterranean diet, like I'm somewhat familiar with that, and I don't know if that's going to be a very good control, because it's like, how many IBD patients do you see that are having symptoms that are on the Mediterranean diet? I feel like what they're going to see is like both the Mediterranean and the SCD could potentially be beneficial. And it's like, is that the Mediterranean diet? Is that like the current status quo? Is that what most people on IBD are eating? No, it's not. So I don't know. Maybe I just don't understand the study, but that doesn't seem like a good control. I think my thinking is that the control should be like, what do people typically eat? currently if they have IBD. And
I agree with you. I think the Mediterranean diet, if somebody follows that compared to the standard American diet, they're probably going to get some benefit. They're going to overall just feel better.
Yeah.
But the problem with using the standard American diet is that whenever you have a control in a clinical trial, you can't just tell people, just do what you're doing. There has to be an active intervention on the placebo side that's comparable to the specific carbohydrate diet, because there's all this research about like placebo, and some people will feel better just by doing something, just by putting a lot of effort into following some new protocol, or when you're talking about drug trials, they try to, whenever you investigate a medication, the placebo has to look identical to the active drug, and then the patient is blinded, so they don't know if they're getting the active drug or not. So here they're going to put people on diets and not tell them if they're on it's just going to be like diet 1 versus diet 2, and they're going to be giving very detailed instructions by a dietitian, and in order to make them seem as comparable as possible. But I agree with you that if you do that, you may not see as much of a difference. But really, the Mediterranean diet is still very different from the SCD when it comes to, like, I think the Mediterranean diet is like orders of magnitude easier than the specific carbohydrate diet. Just the restrictions aren't there as far as the number and to the degree of how strict you have to be. So, but I agree. It's so if they do see a difference, it's a good thing. But they had to pick some sort of control, and they picked the Mediterranean diet because that's what most gastroenterologists are recommending nowadays. When you ask them, "Oh, what kind of diet?" See, this is what is said. Like if you're a patient and you see most gastroenterologists, what they'll tell you is that, there hasn't been a diet that has been shown to decrease inflammation definitively yet. Yeah, there are trials out there that may show a little bit of an effect, but we don't have a high-quality, randomized, placebo-controlled trial to show that a diet is anti-inflammatory. Diet can influence symptoms, like if you eat a bunch of prunes, you can have diarrhea. And that's with respect to anybody, even if you don't have IBD. But so in that sense, they say avoid things that you may not tolerate. But and then they say we just advocate generally a healthy diet, and then they say Mediterranean diet, and that's how they come to that conclusion. But if you read the paper I just published, I go through all the evidence regarding how diet can influence inflammation, and there's a lot of data out there that there are mechanisms there of how diet can make you inflamed. So it's just we don't have good studies yet, and that's where the hang-up is. But another thing I wanted to mention about the Mediterranean diet, and people just say like, "Oh, that's the healthiest diet," and what I always say is it the diet, or is it just the way people live in the Mediterranean? Like they get more sun exposure, they're more active, they're more socially connected than we are here in the United States. So I don't know if it's all diet. I mean, there's so many confounders out there that you can't just link it all to diet. That's another thing that that is, if you want to take things even a step further than diet, you can, by addressing some of these environmental things that are not always addressed.
Yeah.
So, and the other thing you said about SCD, how people can be a little bit dogmatic about it and not branch out a little bit and try to experiment to find out what diet really is best for them. I agree. I think over time, SCD is a starting point, and then from there you can figure out. Like for me, I figured out that I don't tolerate eggplant. I don't tolerate the dry curd cottage cheese. I don't tolerate the yogurt. Actually, I use kimchi instead of yogurt.
Okay.
And so there's subtleties, and everyone I've spoken to it's like the same story. Who's been on this like long term, is that they figure out there are certain subtle differences that are better for them.
Yeah. Absolutely, absolutely. Yeah, and that can be so frustrating in the beginning, because like maybe for you, excuse me, maybe for you, you were trying the yogurt in the beginning, because like that is an SCD. That's like the core critical component that you have to have, or else you're not doing the SCD right.
Right.
And so I imagine for you, like when that's not working for you, that's really hard. That's a real struggle.
Right.
And so you had to branch off and do kimchi, which I don't think the SCD talks about, even mentions.
No.
But kimchi works for you, and like that's awesome. That's what you have to do. So like for me, I'm an athlete. I've got a hockey game later tonight. I need carbohydrates, so I eat sweet potato and dates. And so dates are allowed on the SCD, but sweet potato is not. And I tried sweet potato probably just within the last 2 or 3 years. So I had already been on SCD and GAPS and just, dietary interventions for like over 10 years before I tried sweet potato. And it took a while. Like, I wouldn't say I had diarrhea, but I definitely had a lot more gas, a lot more gut motions. I don't know, just weird feelings in my gut. Took a few months, and then just like a light switch turned on, and my body was like, yeah, all right, I'm doing this. I can do it. So yeah, it takes time, and people, rightfully so, they have their life to live, and they want that solution now, but it takes a long time to experiment, figure it out. Data tracking is a really difficult thing to do, but it's important.
Yeah. So. I mean, what I advocate is that the best way, and ultimately you're coming up with an elimination diet, right? You're coming up like with what works for you. Mm-hmm. And really the best way to figure out what you tolerate and what you don't tolerate is really looking at objective data. Sometimes this is realistic and other times it's just not possible, but when you're reintroducing foods that, after you've been stable for a while and maybe you've had a scope that showed that you're like completely healed, and then there's the question, can I expand my diet? That should be done very systematically by getting, testing, like introducing a food, eating it like every day, increasing amounts over the course of weeks to months, and then checking a fecal calprotectin, which tells you, it's like a stool test that tells you how much inflammation is there. So you check that before you add the food, and then you check it after several weeks to months to see if the inflammation went up. Because you can have symptoms, again, like I said before, related to foods, but is that really making the inflammation worse? And the only way you can tell is by either looking in with a scope or doing a stool test. Mm-hmm. Or looking at labs. So
yeah. Unfortunately, as you know, that's expensive. But it'd be so. Yeah, I agree. Like if you've got the money and you've got the time, like that's the way to go. And then you're going to get peace of mind. You're going to know for sure whether that food is causing inflammation or not.
Right. Yeah, and there are people spending tons of money. I'm sure you've heard of this whole like biohacking community, and there tends to be an overlap with the paleo community and biohacking, and you hear about people on keto diets and intermittent fasting, and they're spending tons of money on getting labs on themselves, and sometimes from labs that aren't really like FDA approved or approved by.
Right.
We don't know if the results are really valid, but a lot of people are doing this and trying to figure out how to optimize themselves by, experimenting on themselves, trying different things, and checking labs. So,
right.
So I just wanted to go through a few more things that I just saw in your movie, and if you just wanted to, briefly comment on them.
Sure.
So low-dose naltrexone.
Oh, yeah.
This is a medication that is still considered on the complementary and alternative side because it's not still part of the traditional armamentarium that gastroenterologists use, though some do use it. I see it more used by integrative medicine doctors when they're treating IBD, and it's also used off-label for like multiple sclerosis, multiple other conditions. The way this medication works is it blocks mu-opioid receptors. People tend to use it at night, and it's naltrexone, but it's at a very low dose, usually 4.5 milligrams. You take it at night, and what it's thought to do is it blocks those receptors, and then your body compensates for that minimal blockade by producing more endogenous opiates, which may have an effect on immune cells. It may inhibit the proliferation of B and T cells, and it's thought to block something called toll-like receptor 4, which also may have immune consequences. So you actually went over this in your movie. So can you tell us what your experience has been with that?
Yeah, so I'm just trying to think back to that. It's been a while. So I took a cream form, a transdermal form of the low-dose naltrexone. And the reason I did that, like looking at the research, I just want to put into more lay terms what you were talking about. When you take a low dose of naltrexone, it blocks the opioid receptors, and your body, after a few hours, when the medication wears off, your body's like, okay, I don't have enough endorphins. I'm going to produce more. So you get this overdose of endorphins. Overdose is probably not the right word, but your body produces more than it usually does. And that can boost the immune system, and it's been shown in some studies out of Pennsylvania that it can also create mucosa healing. And so you get a similar benefit when you're social. And, after you're social with people and you have a good time with people, like you feel lighter, you feel healthier. So it's got that benefit with the endorphins. So I, working on the documentary was pretty solitary, and I was like, this totally makes sense to me. So I took the transdermal cream, and man, yeah, I definitely had some visible changes in my stool for the better. And let's see, trying to think of like, I was already on SCD, and so it's hard for me to say like what else it changed because I was already doing well, but I just remember, stool wise, definitely had some positive changes with that. Over my subscription ran out, and so I think it was maybe like another few years before I took low-dose naltrexone again, but I took it in a different form. I took it in capsule form, and that, okay. I'm forgetting a piece of information. I've had acne as, when I was a teenager and all throughout my adult life. I'm 38, and I still get acne on my chest and my back quite a bit, and sometimes on my face. And so, and I do believe there is a connection between that and Crohn's and just a gut condition. When I took the low-dose naltrexone in transdermal cream form, my acne significantly decreased. And so I know there's some connection with the gut. So that was the biggest benefit. It wasn't so much my Crohn's, but my acne really improved in clarity. So then over the years, later on, I took capsule form of low-dose naltrexone, and I did not see much of a benefit from that. And I think it even interrupted with my sleep quite a bit. It was kind of like taking some sort of caffeine stimulant. It just was not restful in my sleep at all. And so, I've always been doing diet, and just every year I've been getting better with that. So I don't use low-dose naltrexone anymore, but it did have some benefits for me.
Okay. I can just briefly go over what the data shows behind it. There was an original study in 2007 And it was a really small study. It was just in Crohn's disease. There was 18 patients. It wasn't placebo-controlled. It was just giving it to 18 patients without a control. But it did show that patients achieved a clinical response and a clinical remission. But they didn't do like endoscopic. They didn't demonstrate like mucosal healing. And there've been a few studies published since then. But the most recent Cochrane review, which is an organization who does very detailed reviews and really strictly going by the data, and looking at induction of remission in Crohn's disease in 2014, and they said there was insufficient evidence. They did say there was a small study that there could be a benefit for clinical and endoscopic response, but not necessarily remission compared to placebo. So it's just there's too small numbers, not enough studies to really make a definitive conclusion. I am on low-dose naltrexone. I've been on it for many, many years. And I've had similar experiences with it as you, in that it kind of disturbs your sleep a little bit. I definitely end up waking up once a night because of it, and I've gone off of it and have slept through the night. So it definitely has some sort of effect on your sleep. At least for me, and that's not for everybody. Actually, most people, there's no difference from placebo, so it tends to be a very safe medication. But I have noticed a little bit of a difference when it comes to going off of it, and it may be that it can have a minor effect. I don't think it has a very profound effect on inflammation or symptoms, but it may lead to like mild improvements in my experience. I can only speak from my experience on these things. I know it's tough to talk about these things when there isn't a lot of evidence, and I don't want to put out information that's not accurate. But all I can talk about when it comes to something that I've tried is my own experience, and people can take it for what it's worth. But
what form?
So I take it by pill form, and I make sure I get a filler that's consistent with the SCD, and mine's filled with magnesium stearate. So technically that's allowed. So
have you?
Go ahead.
Sorry. Have you thought of trying transdermal or liquid? Because I'm a big proponent in that the form that you take something in can have a huge impact in terms of like how your body uses it.
Yeah, I've been meaning to try transdermal to see if it makes a difference, but I'm okay with it right now. I don't want to kind of like, I at some point I'll probably try it, but right now I'm happy with how I'm feeling on the form I'm taking. So, I'm just sticking on it. But yeah, I am familiar with that. I'm familiar with people who take it during the morning instead of at night. And even some of the clinical trials I've read, they do give it to people in the morning if they don't tolerate it at night. But then I've read some people say it's not as effective if you take it in the morning. So I don't know. I really don't know what the optimal way to take it is.
And that's, that goes back to our earlier point of where you just, if you personally feel comfortable with it, this is just for not you specifically, Samir, but for the listeners, if you feel comfortable with it, feel free to experiment with the time and dosage in a very small amount. I always recommend that people, like, let's say I recommend to somebody, you should try kefir. Well, I always recommend take a very, very small amount, like 1/8 of a teaspoon, and just see how you do with that. Because people have told me that they've had very strong reactions to kefir just with how potent it is as a probiotic. So as always, start things small, low dose, low frequency as well. Try something for once on day one, and then skip several days or a week and see what happens. If nothing, then maybe increase the frequency of every other day. If nothing happens, then every day. And then if nothing happens, then increase the dose. So, always want to be safe. But if you can experiment and try different ways of doing things, whether it's a cream or liquid or capsule form, I think that can really help.
I agree. Yeah, everything in small amounts and with increasing dose over time makes sense. Okay, and then I know we're already at an hour, so let me know. Are you okay to go a few more minutes over?
I am, yeah.
Okay.
Yeah, as I said earlier, don't really have many of these conversations often, so I'm really enjoying this, so we can keep going.
Okay. So next, what about the person in your film who did a fecal transplant? And just a little bit of background on this. Fecal transplant is a treatment where pretty much you instill stool into the colon or small intestine various ways. You can either be done through putting a tube down through your nose into your small intestine and putting stool in that way, or doing it through an enema, or you can do it through a colonoscopy where a physician puts a camera into the colon and sprays it through the actual scope into the colon. And this treatment is not something new. It's actually been around in various forms even since like thousands of years ago. I think the first description was in the ancient Chinese medical literature, like ancient Chinese medicine. They were using this for diarrheal conditions. But more recently, it's been used for a particular infection called Clostridium difficile. And it's been used for people who don't respond to antibiotics, and it's been very effective in that. And then people started getting interested in inflammatory bowel disease, because we know that people with ulcerative colitis and Crohn's disease have a less biodiverse microbiome. They have less diversity in the bacteria in the colon. So this acts as almost like the ultimate probiotic. And so there was enthusiasm for this approach. But I can tell you that the clinical trials that have been done in ulcerative colitis have not been that encouraging. I mean, there is some, it seems like there can be some benefit, but it tends to be like donor specific. If you have the right donor, like I remember in one of the clinical trials, it was like one particular donor that led to better results compared to the other ones. So obviously it's the mix of bacteria that you get that may have an influence. But what was worrisome for me was that there were actually people who got worse. So there were some people who got worse with fecal transplants, and also the long-term consequences of doing a fecal transplant are unknown at this time, because we don't know all the components that are in stool. So is it possible that years down the line, if you're getting a transplant from a random donor from one of these companies, and later on you develop some disease, possibly transmitted through this, even though they screen the stool for infectious diseases, but what about like other autoimmune diseases, etc.? We just don't know. So there's a lot of unknowns, and it's not like a pure pharmaceutical drug that we know exactly what's in it. So that's kind of where we are right now in our field. With it's not mainstream. It's only being used within the context of clinical trials. If you have inflammatory bowel disease. One exception is if you have inflammatory bowel disease and you have C. diff. Those people sometimes do get fecal transplants outside of a clinical trial because they're treating the C. diff.
Yeah. What's interesting to me, though, is like, I'm definitely very cautious about fecal transplants, and I haven't done it. I don't plan on doing it because of all of these unknowns. And all the research that you need to do. Like, you really need to interview the donors and know them well, know their lifestyle, know what they put into their bodies. And it's a lot of work to be able to find a good donor. And I don't need to do that. But it's just really interesting. Like, for cases of just pure C. diff, doesn't it have like an over 90% effectiveness rate?
Right. Yes.
Yeah. So if it's just pure C. diff, it's like it should be the go-to treatment. But then you have something like Crohn's disease and ulcerative colitis. Like, they look very similar on the surface level to C. diff, like very similar symptoms, but the results are just not the same, not even close.
Mm-hmm. Right. So you had someone in your movie who was doing it on his own, right? He was just not with support of a physician. He was, and I think if I remember correctly, was he doing it with like enemas? He was doing it through using enemas.
Yeah. Yep, that's right. I thought, I could be wrong, but I thought he at least found a doctor that said, like, if something bad happens, I'll treat you.
Okay.
But I think that was it.
Okay. Yeah, and I mean, there are definitely people doing this. The guest I had on for the first and second podcast, he had done fecal transplant with his baby's stool, which was pretty bold thing to try. But he didn't get any benefit from it. And so I'm not too bullish on it. I think eventually they may figure out some like the optimal kind of combination of bacteria for particular patients. Again, I don't think there's a one shot thing that's going to fix everybody. But yeah, it's like they have to get your profile and figure out what you need and somehow come up with a concoction that'll address that.
So did your previous guest explain why he thought a baby stool would be better? Because that doesn't compute for me. Like, a baby's microbiome diversity is not going to be mature, I don't think.
I really think the only reason he used it was because it was a convenience store stool. It was available, easily attainable, and he just thought, why not? So, because, I don't know if you've listened to those episodes. If anyone's listening, I encourage you to listen to those episodes, because he really went through the ringer when it comes to trying a lot of different things, including SCD. But it ultimately didn't end up working for him.
See, that's the thing. Something else that I've thought of is, like, a lot of people do try fecal transplants, but they read one story of, like, yeah, I did fecal transplant once and it saved my life and I can eat pizza and it's great.
Right.
So they think, like, one treatment is going to cure them, and I don't think that's ever going to be the case. It's, again, I think it really goes back to our lifestyle, how we live, how we eat, and if you really want to have a diverse microbiome, it means changing your diet. And so if you do a fecal transplant and it does work, you have to maintain it. You have to cultivate that microbiome diversity, and you're not going to do that with just one fecal transplant. So, like, you do it once, you kind of, like, seed your gut, but then you need to feed it with all of the food and other fermented foods. I think fermented foods are, like, a secret weapon in all of this. It's, like, so important to do that. So I'm glad you're doing kimchi.
Yeah.
I do kefir and kombucha. But again, I don't want people listening to this and thinking, like, oh, fecal transplants, that's my one answer. It's never going to be one answer. It's going to be a whole host of things that all work together.
Right. And it takes a long time to figure out what combination of things works for you.
Yeah.
And that really is the key. It's the similar message that I say. And I hate to go back to, like, medications again, but medications should not be ignored either, because for some people, and actually most people nowadays, require some medication as well. There are people who have at least clinical remission and are feeling well doing these alternative things without using medicine, but it's the medicines aren't something to just ignore, because I actually think the most potent results are using both for most people. Like, if you use just one or just the other, you may have suboptimal results. But if, at least initially, especially when people are sick, or, like, really sick, sometimes you need some support from the medicines too.
Yeah.
So, okay, we talked about fecal transplant and cannabis oil. That's another thing that I came across in my research too. Lots of patients coming in nowadays asking about medical marijuana, and at least where I'm from, Illinois, it is approved. As long as you have an approved diagnosis, you can get medical marijuana.
Okay, good.
So what has been through doing this film and interviewing the people that you've interviewed? What's been your experience with that?
Yes. So I grew up in Massachusetts on the East Coast, and growing up, like, it's just not something that you did. It's not something you talked about, drug use with marijuana. It was just really like a taboo, unknown thing for me.
Right.
And so it was really scary for me to, like, even just talk to somebody on film about their use of it. And this is Jay, Crohn's boy. So he introduced me to the to THC oil. And so THC is a chemical component of marijuana, and there's two primary kinds, THC and CBD, and both have been found to be, in some studies, to be beneficial for people with IBD. The CBD I've tried in some forms, just never really seems to help with me. But the THC form, the really high content of THC, that's like, it was really amazing, but it also really messes me up psychologically. Like, I will have these crazy vivid dreams, and my sleep is disturbed. Like, I'll be shaking in my bed. I get paranoid. In the past, I've taken too much, and I've been up all night throwing up. I've had some really bad traumatic experiences with it, so it's not a treatment that I use on a daily basis. It's really, I'm just not, I try to avoid it if I don't need it. But with the experience that I've had, like when I took the THC oil and had that really, really vivid experience of like crazy dreams and shaking in my bed and being paranoid, but for like a week after that, like I could eat whatever I wanted. So as I like to say and joke, it was like a superpower with consequences. And so I think for some people it can be really, really beneficial. And, you know, a lot of people will take the cannabis oil. It's just like almost like a teardrop, and they put it on their tongue and they go to bed, but it's super potent, so they sleep through the high. And it seems to really benefit. And it's really interesting where a lot of people, including myself, I'm one of those people that feel like my IBD has some sort of psychoactive component to it, where like if I'm really stressed out from work, or if I don't get enough sleep and I'm stressed, my symptoms worsen. And so the THC having the effect on my psychology just really seems to ease my gut and make my symptoms a lot better. So, and I've talked with a lot of patients in the past that say like, yeah, when I'm really stressed out, my symptoms get worse. So, you know, maybe for those people, the THC is better. And then for other people that don't find that, maybe the CBD is better. I don't know, but it's really interesting to me.
It's really controversial right now in, you know, when it hasn't definitively been shown that medical marijuana leads to better outcomes, leads to mucosal healing. Obviously, we expect it to make people feel better, but we don't know for sure if it leads to decreased inflammation. And part of the reason there aren't good trials out yet is because of all the restrictions on use, and you know, I believe it's still illegal federally, right, to use.
Yeah.
It's like there's only state governments are allowing it to be used. Right. So we haven't studied it properly, and a lot of the trials that are going on are like outside the U.S.
Right. In Israel, I think they have a lot of trials for this.
Right. So, and I think there is some early signs that, you know, maybe it can have some influence on inflammation. At least they've figured out like a mechanism of how that is possible. But the jury's still out. I don't know many people using it. I've just seen people on the internet who claim that it's like the best thing. But we don't have good evidence as of yet.
Okay, so you may not be able to answer this, but have you tried it?
I have not. No, I can't because, any job I take, or there's always drug testing, and for any kind of employment, there's always like a urine test. So I have not tried it. No.
Yeah, that's too bad.
Okay, what about colloidal silver? This is
this is probably like the most controversial out of all of them, I would think, because it's like the most weird, right? Like you search up colloidal silver on Google, and you're just gonna see Smurfs. And you're like, what the hell is this?
Right. So you're referencing the condition argyria, which is where you have these. So colloidal silver is a supplement that some people use. It's been around forever. I mean, most physicians now consider it as, in the alternative realm. It's even on quackwatch.com as far as one of these supplements that has a lot of quackery associated with it, mainly because of people who are making claims about what it can do. But it's not FDA approved to treat any condition, and but the claim that's usually made is that it's like a natural antimicrobial, like it can kill bacteria, funguses, viruses, and somehow be able to do that, but not lead to resistance or some of the other problems associated with pharmaceutical grade antibiotics. And one of the things that was happening to people and why it was brought to the attention of the government was this argyria condition where people were turning blue. Like, as you said, they were looking like Smurfs because the silver salts were depositing in the skin and they were turning blue or silver. And sometimes that can be like a permanent thing where it just doesn't go away.
Right.
But I know in your documentary you mentioned that I think there was like a machine you showed that some people are actually making it, and the actual incidence of this argyria happening, although it's like unknown, like how commonly it happens, but you seem to suggest that from your research that it's actually a very rare thing.
Yeah, that's what I've found. And the thing with me is like, I only wanted to take it like a few times. Like the people that turn blue are the ones that seem to drink it every day, like it's water, and it's not water. It's a certain treatment that you should use with a very specific purpose and idea for why you're using it. And so, like you said, it's a antimicrobial. So I can remember the early times that I drank it. I definitely did have changes in my gut. I could feel, gas forming, and definitely something was happening in my gut with that, like I would experience with an antibiotic. So, definitely has that action. I've also, and I know that this is extremely anecdotal. I've seen very few references, and the person that introduced it to me said he also experienced this, and he heard from a friend that also experienced this, that it can really help with scar tissue. And so what's really interesting, and I know I need to get confirmation on this through a colonoscopy, because previous years with a colonoscopy, they have shown that my terminal ileum was forming strictures and closing up. And over the years, I had to remove fibrous foods like carrots and pepper and other things that were actually giving me obstructions, like partial bowel obstructions. Like I would have excruciating pain, and I would be constipated, couldn't poop, couldn't have a bowel movement because of these partial bowel obstructions. And so I was experiencing these, and tried the colloidal silver. And unfortunately, the data is not clear because I also tried the THC oil at the same time. But ever since then, my partial bowel obstructions, every time that I've had the colloidal silver, I've noticed that like I've been able to widen my diet to the point now where today I don't have partial bowel obstructions anymore, and I eat, all the foods that were fibrous and giving me problems before, like carrots and spaghetti squash and any kind of vegetable, lettuce and kale. I can eat all of that, and I don't have partial bowel obstructions anymore. And I asked a doctor one time, I'm like, do strictures in the terminal ileum ever go away? And they're like, no. And so I really need to have a colonoscopy, and I haven't yet, and it'll be fascinating to see if there's been any kind of structural change to that area. So I feel like it helped me, but I know it's like there's so little data that's credible that's out there. But this is just my own personal experience with it. It tastes like water. I drank 8 ounces of it probably on 3 separate occasions, like months apart. And I always made sure to have some sort of probiotic after I drank it, because I do think of it as an antibiotic, and it's not something that you want to have every day.
So I agree with what your physician said, that, to our knowledge, strictures in the terminal ileum, there's 2 different kinds. There's like a fibrostenotic stricture, which means it's a stricture from actual scar tissue. And then the other type of stricture, there is such a thing as an inflammatory stricture, where you have narrowing, but it's just from the inflammation, the swelling, from the actual inflammation itself, but it hasn't actually scarred down into scar tissue. So to our knowledge, there's no medicine that has been known to take away fibrostenotic strictures. But if it's an inflammatory stricture, then those can respond to at least medications. I don't know about colloidal silver specifically. There's no data regarding that, but definitely the medications that we use in the standard of care for Crohn's disease have been shown to help relieve those strictures. Mm-hmm. So one of the major ways we tell if a stricture is from inflammation versus from scar tissue is if you've had imaging study, if you've dilation of the bowel upstream from the stricture. If there's dilation, that means that stricture's probably been there for a long time and is probably fibrostenotic. But if there is no associated bowel dilation upstream from the stricture, then it may be inflammation. But sometimes it's hard to tell.
Okay. Yeah, I'm not sure what you even mean by dilation.
Like just that the small intestine usually has a normal caliber, a normal diameter. Oh, yeah. And they'll usually comment on the imaging, the radiologist, if the bowel is bigger than it should be. Okay. Just like proximal to where the stricture is.
Okay.
And it may extend even further up, the dilation. So.
Yeah. The whole thing with colloidal silver is just it is really weird. There's like one mention in this really obscure small like self-published book that I have that like it can promote stem cell growth, and so if that's true, then that might be how if my strictures if my strictures were fibrous, and which I think they were, if they're fibrous and they went away, perhaps the colloidal silver, if at all possible, somehow got my stem cells to regenerate and like repair that tissue. But who knows? Like I said, it's really weird.
It's difficult to say.
Yeah.
But yeah, we usually don't see fibrostenotic strictures go away, so it'd be interesting if you got a scope to see what it looks like.
Yeah.
Okay, and then I just had a couple more. There's a few other things that I've actually tried myself, and L-glutamine is a supplement that I've been on for a long time too. And,
really? So can I ask you about that?
Yeah, sure.
All right, so I was on it for a long time, and I noticed that my memory started to go. And I talked with a friend of mine who was on it for a long time, and he also noticed that. And so I just want to caution you to be aware of that, or have you noticed any other kind of side effects?
I have not noticed any effect on my memory. But that's interesting. Is this something that's been reported in the like in the medical literature, or is it just something that's kind of like anecdotal you noticed?
Yeah, I can't remember exactly where I read it, if it was in medical literature or if it was anecdotal, but I do remember seeing some sort of mention that like too much glutamine can get up into the brain and affect it. So
I do think I do remember reading something like that too. I mean, definitely glutamine can have influences on the brain and neurotransmission. So I'll have to look into that. I've been on it for a long time. I had tried it a long time ago, and I remember I did get some benefit from it.
mm-hmm.
Then I stopped it for a long time, and then for some reason I restarted taking it, and it's just been part of my regimen for the last several years. And I've had colonoscopies that have shown complete mucosal healing. So, whenever I get success, I tend to stick with what got me there.
Yeah, absolutely.
And that's just been one of the things that I was like, okay, I was on this when I had a perfect scope, so I should probably stick with it. But no, I mean, you bring up a good point. You take these supplements for long periods of time, and sometimes you just like forget about it, and they just become part of your routine, and you don't know. I mean, they could have adverse effects if you're taking it for long periods of time. I've tried going off of it, like when I've run out of it.
Yeah.
And I do notice feeling a little bit worse. But
yeah,
I mean, who knows?
So for me, like, it's been a long time since I've taken it, and I'm looking at my website and one of my blog posts about it. So I'm just like reminding myself like what it actually does, and I describe it as the fuel for the small intestines. And I was taking it because I really feel like it helped reduce that stricturing and that partial bowel obstruction pain that I was having.
Okay.
So what does it help you with?
I just think just overall, like, kind of, it's more like bloating and like abdominal discomfort, that type of thing. It helps with. So yeah, I mean, I don't think it's a very potent effect.
Right.
Again, my general opinion about these supplements, and I've tried probably hundreds of them over the years, just out of curiosity, doing like these short trials of them. And I feel like most of them don't work, but some, if they do help, it's like a very mild effect. Like if you stop taking it, you may notice a little bit of a difference, but it's not very potent. Has that been your experience too?
Yeah, I'm trying to think back because I actually don't take a lot of supplements right now.
Me neither. Yeah, not anymore. But at one point, I tried many.
The supplements I take now, interestingly enough, are like just dietary enzymes, betaine HCI, zinc, copper, and vitamin D. So vitamin D is definitely a staple. I've been taking that for years. I'm sure, I feel like there has been probably like a supplement or two that was like extremely beneficial for me, like colostrum.
Okay.
I think I've taken that just a few times, but like when I took it those few times, it was like, okay, this is the next level of my healing. Yeah. I'm trying to think of what else. I mean, the colloidal silver, I feel like potentially was really, really huge. Let's see. There's probably others, but I can't
Those are the
remember
ones.
them now.
Yeah, colostrum I've heard some people use, and my understanding is that it's pretty much a collection of immunoglobulins that are, it's like derived from cow, like I forgot, is it like cow placenta or something?
Yeah, I think it's something like that. Yeah.
And it's this immunoglobulins, which are these proteins that bind to certain bacterial products and infections and allows them to be cleared more efficiently. Again, no data, but some people, there's anecdotal success from it. So,
yeah. Don't some people try to take derivatives of human placenta because they think like they're going to get the stem cells from that?
I haven't heard of that. I'm not aware of that. No.
Yeah.
That doesn't sound like a good idea, though.
Yeah.
Okay, and then this was just the last thing. Helminths.
Oh yeah.
You had somebody who had tried hookworm therapy, right? On your.
Yeah.
And my sense is, I've actually tried hookworm therapy too.
You have?
Yeah, I did it years ago. And I'm intending to do a whole podcast on like my experience with all these treatments I've tried at some point in the future. But
cool.
Pretty much the short version is, yeah, I tried it and it didn't end up working out for me. I've met very few people who've actually had success stories from using it. And actually the clinical trials that have been done have not been too encouraging as far as the results. Generally, it seems to be not very effective. I was convinced just based on the theory behind it, that we're too clean, the hygiene hypothesis, and that's why our immune systems rebel because we're just too clean. So maybe it makes sense to have hookworms in you. But it didn't really. It actually ended up making me feel worse. So I completely ridded myself of all the worms by taking medication. So I do not have that anymore, and that was confirmed endoscopically. But you had somebody in your video who did it.
Right. Yeah, I did. And he really feels like after he got over that initial phase of where you do feel really sick for having them, because like your immune system is like, what the heck are these things? They need to get out. After that initial phase, like he felt like it really helped him. And he was tracking his data. Like he had an app on his cell phone and he was tracking his data. And then at some point he realized like, hey, it's been several weeks since I've had abdominal pain and I haven't been throwing up. So this seems to be working for me. But then he had trouble getting access to them after a while, and so he had to stop taking them.
So that's the issue. It's like, just getting inoculated, that doesn't mean that's the end of it. Like they at least what I was told was that they tend to last about a year or so. And if you get like a flu or something, you can actually lose the worms, or you get really sick, or sometimes you can lose them for no reason at all. And then you need to get re-inoculated, and that can either be done by getting another shipment through the mail or traveling to some place and getting re-inoculated. Or some people actually act as their own reservoir and get the eggs from their own stool and stuff like that. That's that's the
biohacking.
Right. It's a very involved procedure, but overall what I say is I don't recommend it, just because I can just go over the clinical data that we have so far, and even my own experience, it wasn't helpful for me. So I don't recommend it to people, and it can make you sicker. Like there's some people who just get worse. I've seen at least a few people, not people I've scoped particularly, but colleagues of mine that have scoped patients who've done worse, and they scope them and they see the worms and they see the inflammation still there. So obviously that's still anecdotal too, but the clinical trial available clinical trial data that is available now is it's not like that great data. So
yeah, it's not promising.
Right.
Yeah, that's too bad, because like there's definitely like there's some online communities, and there are people in there who definitely do say it's benefited them. So I wish there was some way to like study them and see what the difference is. Like why did it work for them, or is it really working for them, or are they just saying that it worked without really knowing for sure? I just wish there were more studies about that.
And again, it comes down to this disease having many different likely causes and combinations of causes. And certain people respond to things, other people don't. And just because a clinical trial says it doesn't work doesn't mean there could be a few people who have benefited from it. So it's tough. This is a process where I compare it to finding like you have a lock, and you need to find the key for your particular lock to open it. And many times it requires multiple different keys. And it's just a trial and error type of situation to figure out what works for you.
Well, how about this analogy? Like, instead of just one lock, maybe there's like 500 different locks. And then there's like 5 million different treatments that could go with like one of those 500 locks.
Yeah.
Because like I've talked with I think it's Dr. Rubin. He's I think that's the gastroenterologist. He's one of the more well-known gastroenterologists that works with the Crohn's and Colitis Foundation of America.
Oh yeah. And this is at University of Chicago, right?
Yeah.
Yeah. Okay. Yeah. He's one of the top IBD experts in the world.
Yeah, so I was trying to set up an interview with him for my documentary years ago. In our phone conversation, he and I both agreed that there's probably like we just have these two conditions, ulcerative colitis and Crohn's disease, but there's probably like hundreds of different like subtypes that you could like classify. And so really it's not that somebody has Crohn's disease, but they have like Crohn's disease subtype like 78 or whatever. And like that's why it's like so difficult to find the right treatment, because like you can't just group everybody's condition into like one of these two types of IBD when there's really like a lot more of them, and they're really different in how you should approach treatments for them.
And by the way, there's probably a lot of people out there who have Crohn's who just don't get diagnosed, and it's mild Crohn's disease, and they don't end up getting scoped, and it doesn't end up being severe, but they may not even have symptoms from it, and they just have it their whole life. There's probably significant amount of people like that in the world.
Did you say, I'm not sure if I heard you right, did you say that there may be people that have Crohn's that don't have symptoms?
Yes, yeah.
Oh, wow.
I mean, we see people all the time who end up going to the emergency room, and usually, they do have some symptom, like some, or they may just like incidentally, we know on their CT scan they have some inflammation in their terminal ileum, but they don't have any symptoms, or maybe they had some symptoms that just like went away, and they're no longer symptomatic anymore. And we do a colonoscopy, and they have these few ulcerations in the terminal ileum that look really mild. And a lot of times for those people, we don't treat them, especially if they're not symptomatic and they don't have any features that suggest their disease is going to progress or be severe. We just closely monitor them. Some of those people will require treatment in the future, and some won't. So, all right. Well, that was my list of questions after watching your documentary. Again, if you can remind us how people can find your website and how they can see your movie.
Yeah, absolutely. So they can visit crohnsend.com. That's CROHNSEND.com. And the movie, the trailer for it is right on the front page, so it's pretty easy to find.
Okay, great. So I encourage everybody to take a look, and just because it's just interesting. I thought it was very fascinating to see these people's stories, and to see what things people are trying. And then Reid, did you have anything else you wanted to mention, or any questions, or?
No. I mean, I know that you've been doing treatments, so my question would be to hear your story, but I think you said you're going to do a podcast about that. So I definitely encourage you to do that, and I look forward to hearing about your experiences with all of this.
Yeah, I do plan at some point to do kind of it's probably going to be a multi-part thing, because I think I do have a unique perspective that I do want to share, because I think I started out with this diagnosis of Crohn's disease, and it's really come along with many twists and turns. That initially, I was diagnosed in medical school, and I, like you, my journey started with a specific carbohydrate diet, and it's been many, many years of trying different things, and ultimately finding success, and then ultimately specializing in this and training with some of the top, inflammatory bowel disease physicians in the world. And so I've kind of been on both sides of the curtain. I've been on the side of going down that internet rabbit hole and trying all these things and being confused and getting really devastated by side effects of medications, and demonizing medications and being absolutely afraid of them and against them, and then kind of going through the training and seeing the other perspective of why we use these medications. And now I'm kind of developed this framework in my mind of how to address these conditions. So yeah, I plan to do a podcast. When that is, I'm not sure. Part of it is just being comfortable telling my story too, which it takes time, and but eventually I will go through all the details, because I think it is a good thing to learn from what I went through.
Yeah, absolutely. I completely agree. That is a very unique perspective, and one that's much needed, just so that you can connect with your patients and so that they can feel like they have a partner in this. So kudos to you for going on that path of, being on both sides of the spectrum.
Oh, thanks. Yeah, I just think it actually helped me out, because in medical school, I didn't really have any particular interest. I went into medical school not knowing what I wanted to do, but then this happened, and I was like, all right, I might as well do this, because it just helped me to get up every day in the morning. It's like, okay, this is actually something I'm interested in learning about.
I got to figure out how to cure my own shit.
Right, exactly. And then actually, believe it or not, I was going to be a dermatologist before this all happened. Mainly because I had a good lifestyle, and it was I thought I'd be happy, but I knew that I had to pick something that I'd be passionate about and that I'd cared about, and that would ultimately, because it's all about being happy, right? Even when you're trying to figure out these treatments, figure out what works for you, you got to pick something that's going to lead to a better quality of life, and as you said, allow you to reconnect, right? And connect with people and be happy and be passionate and do what you want to do. Yeah,
absolutely. I've found that, if you try a treatment that you don't think is going to work, you're right. It's not going to work. It's half of this battle is the mental game.
Yeah, exactly. All right. Well, thanks again for coming on. And to all those listening, please subscribe. Try to share this on any social media platforms that you can, so that more people can listen. And hopefully we'll have more guests soon. All right.
Yeah, thank you so much. Really appreciate talking with you.
Thanks.